So your YouTube video playlist is not playing tricks on you. This is just the same cover slide. I copied it. We're going to go on to bowel elimination, and then we'll be finished with that and we can move on to other topics. For this chapter, for this section, you're in chapter 29 again. You can also use volume 2 for some of the stuff, but it's a pretty simple unit, so we'll get through it. And then move on to activity, mobility, and some of the other basic needs. Let's do a brief overview of the anatomy and physiology of the GI system so that you kind of can refer back to it when we're in our discussion of bowel elimination. Digestion begins in the mouth when you chew your food. Salivary enzymes break down some of the sugars and starches. When you swallow a bolus of food, it goes down the esophagus into the stomach. I know I'm being really fast, but this is real common sense. I mean, the GI system is nothing but a great big tube with some fancy modifications for digestion. And then you get to the small intestine, the duodenum, and then the jejunum and the ileum, mostly responsible for the absorption of your nutrients, your proteins, fats, carbohydrates, water, vitamins, and minerals. You're going to assimilate all of them into the bloodstream. There's a lot of vasculature there, a lot of the villi that increase the surface area so you can interact with the capillaries, and that takes the nutrients out to the cells and tissues. What's left over then goes into the large intestine. Now this is a waste product treatment plant. It's like a garbage packaging facility. You have a lot of bacteria that break down all the wastes. It mixes with the bile salts that were in the small intestine to become what's known as stool. And the further along the tract you go, the more water is absorbed, and so the more solid that stool gets. And that becomes important in a couple places. When you start to learn about bowel diversions, you'll notice that depending on where the stoma is, the products that are draining into that colostomy bag are going to change in consistency. The further down the tract it is, the more solid the waste is going to be, which is better for that person in a way, because it's a little bit easier to deal with. Then we get problems with constipation because, as I said, the job of the colon is to absorb the water. So if you ignore the urge to defecate for a prolonged period of time, the stool stays in there and it just gets harder and drier and more difficult to pass. And so it's important to encourage people not to ignore that urge. Now, as we get closer down to the rectum and the anus, there are some structures that are important in bowel elimination. We have an internal sphincter, and that sphincter relaxes when there's stool in the rectum. The rectum is typically free of stool until just before defecation. When that happens, the external sphincter relaxes. You start to get nerve signals that tell you it's time to defecate. But you have an external sphincter here at the anus, and that is under voluntary control. So you can kind of hold back and ignore that urge to defecate if you need to. Prolonged pressure on the the veins in the rectum here will cause hemorrhoids. So those are the kind of things that become real important to us as nurses. So now let's talk about normal bowel elimination and some factors that can influence your bowel function. Number one, we have developmental level. I don't want to get you too bogged down in the newborn and the pediatric client, but newborns will stool maybe 8 to 12 times a day. If they're breastfed, it'll be yellow and seedy. It kind of reflects their diet a little bit. Bottle-fed infants will stool maybe 5 times a day, and it's a little more formed because there's iron in it. Children get toilet trained at about 2 to 3 years of age, but soiling can be common in the toddler and preschool years, mostly because they get busy playing and they forget. They have accidents. Elderly people are at risk for different bowel elimination problems. For one thing, their peristalsis slows, their level of activity slows, sometimes their fluid and their fiber intake slows, and very often they're on medications and supplements that can constipate them. So those are some developmental factors that you'll see. Okay, and so then we have personal and sociocultural factors. What's in your book? Basically, personal factors, things like privacy. Patients in the hospital will have a hard time defecating in front of other people, so it's important to give them privacy. Of course, if they're falls risk, we have to be sort of close by in case they need us. But you try to make things as normal as possible. And then we talk about things like stress. Stress can make people constipated. It can give people diarrhea. It sort of depends on which way they sort of lean. There's something called irritable bowel syndrome. and it's how the gut responds to emotional stress. So those things can influence bowel function. And then we come to nutrition, hydration, and activity. And this is pretty much a key category. Now with nutrition, we didn't really talk about it in that big long video, but fiber is, comes in plant-based foods. And it's important to move things along the gut. It's actually like a plant fiber that can't be digested. It's a carbohydrate that the body can't break down and use for fuel. And so what it does is it bulks up the stool by absorbing water and makes that stool softer. Now, without water, fiber won't work. Fiber will actually make your constipation worse. It'll plug things up worse. So if a person's taking an increased amount of fiber, we want to make sure that they're drinking enough water. 8 to 10 glasses a day is normal unless they're restricted for some reason. Okay, so your fiber, your water, your fluids. Then you have foods that have probiotics. You might have heard the term prebiotics too. Probiotics are the good bacteria that help our gut stay healthy. You find them in things like yogurt and sauerkraut and other fermented food. Prebiotics, not as commonly known, but they are other food-based things that help the probiotics, the healthy bacteria, grow and colonize in our gut. And they usually come in fruits and vegetables and plant foods like that, legumes. Now, we talked about hydration, nutrition. Let's talk about activity, and let's put a little star somewhere close. There we go. Because activity increases peristalsis. So when you have those post-op patients and their bowel sounds are kind of sluggish and they're not passing gas and they're getting bloated and they're getting uncomfortable, what do you think a really good intervention for that person is going to be? I know we're not at interventions yet, but ambulation. People who have constipation issues, maybe if we get them up and moving, sometimes we will stimulate a really good peristalsis. And this is especially important for your post-ops. Ambulation is important for your post-op patient for a number of reasons. I mean, we talked about the respiratory issues, and we talked about preventing a DVT. Now we're talking about increasing peristalsis so that we don't get a paralytic ileus, which is when the bowels are shocked into not moving at all, which can be a very dangerous situation. So ambulation is really important, and it's kind of fun because now we're getting to the point where all these little pieces are starting to fit together. When we get to physical activity and mobility, we'll talk more about how activity influences the body's functions, but know that activity is important to increase peristalsis. So if you have a patient who needs to move their bowels, get them up and walking, and that will usually help, if you can, if they're not stuck in the bed. Okay, and then we have things like medications, and there are many medications that influence gut function and bowel function. Some of them are constipating. And I'll give you a couple of examples. Iron, extremely constipating. Calcium supplements, that's another one. We all know cheese is binding. Well, the calcium is kind of something that slows peristalsis. So calcium supplements, iron supplements, and narcotics. Oh, narcotics are notorious for promoting constipation. It can make people really, really, really miserable. It just slows down the intestinal motility. And then we have some that increase the transit time in the bowel and can cause some diarrhea. It's a common side effect of a lot of medications. And first we're going to look for that on the antibiotics. Antibiotics are really rough on the gut sometimes. They kill all the healthy flora. And so we maybe want to counsel these folks to take probiotics, because what may happen in the extreme case, antibiotics kill off enough good flora that the only bacteria left in the gut is C. diff, which is a little encapsulated spore, and that's going to overgrow and give our patients C. diff, which is really, really hard to get rid of and not pleasant for anybody. When we have things, of course, obviously laxatives taken in excess can cause diarrhea. And many, many medications have diarrhea as a side effect. So when you're educating your patients, you definitely want to cover side effects that affect the GI system. Now, obviously, we've talked a lot about the post-op patient here. Let me see if I can move some stuff around. and make this, whoops, let's move our star. Make this a little more manageable. There's a lot of material here. The other thing that I want you to be aware of that can influence bowel function is surgery, especially abdominal surgery and anesthesia, and they slow peristalsis way down. They can even stop it. Now, normally I recover a lot of C-sections when I'm working on labor and delivery. I have a run usually, it'll be 2-3 weeks in a row where I have patients in the PACU. And the normal finding for me, the first time I assess their bowels might be that I don't hear anything. And then by the end of the 1 hour or 2 hours that I have them in the back, slowly I start to hear peristalsis, and that can take a little while to come back to normal. And we've already talked about some interventions that we're going to do. But definitely any kind of abdominal surgery and general anesthesia too are going to impact on bowel function. With that having been said, okay, we forgot one thing under the developmental level. Pregnancy absolutely interferes with normal bowel function because we have a hormone called progesterone that decreases the intestinal motility. It's supposed to maintain a pregnancy, and it works by kind of slowing down all the smooth muscle. Uterus is smooth muscle, intestine is smooth muscle, and so we get a lot of smooth muscle relaxation. We don't get a lot of peristalsis. We also have a growing uterus and fetus that displace the intestines, and that can change things. And we're giving mom a lot of supplements, iron, calcium. Usually that prenatal vitamin can be very constipating. And then you have people who've had perineal surgery, your people with prostate surgery, and also even moms who've had an episiotomy after delivery may be afraid to have a bowel movement because of the suture line, and they're afraid of pain. And so, those are some things that definitely influence bowel function. Let's clean this up now. If you need to take a note, stop the video, take a note of what you see, or do a screenshot, whatever it is you want to do, and then I'm going to take this off here and continue with pathological conditions. And these are some of the pathological conditions that influence bowel elimination. We have allergies, food allergies and food intolerances. Obviously, if you're lactose intolerant, that's going to impact your bowel elimination because you're going to get diarrhea from the food that gives you problems. Your book starts to talk about things like anaphylaxis, which really is not, or mild rashes. Those really aren't bowel problems per se, but the problem does sort of originate in the bowel. The body recognizes the food protein or the food component as an invader, and there's an immune response. However, it's really not a bowel disorder per se. Food intolerances, on the other hand, usually do cause some GI symptoms, including diarrhea and cramping, bloating, excessive gas, those kind of things. So that will impact bowel elimination. Bowel disorders, you're going to cover in more detail in your GI unit, which I want to say is maybe Unit 2 of spring semester. You'll learn about ulcerative colitis and Crohn's, but do know that these are conditions that can really negatively impact a person's bowel function. Some folks have up to like 20 liquid or bloody stools a day. It's very disruptive and it's painful. One thing that I will put under food allergies, I know I said that we really weren't covering them extensively, but you might have something like celiac disease, which is an intolerance to wheat, which can cause some very nasty GI symptoms as well. Now, one last thing, it's not in this section of the book, however, it will become important. So, GI infections. You have bacterial infections like C. diff, you have viral infections, a lot of your gastroenteritis is viral, and you have infections that are due to parasitic, parasites, such as tapeworm or pinworms or ringworms, whatever. And that is in the book somewhere, it's just not on this list in particular here in 750 and 751 with the pathological conditions. However, they do impact bowel function. Usually by causing diarrhea. Diarrhea is the body's way of getting rid of the offensive invader. Okay. So now we need to apply the nursing process for our clients who may have some kind of alteration in their bowel elimination. And we start everything in the nursing process with assessment. So we're going to assess our clients very carefully. The first thing we do is history. And we do a pretty thorough history, keeping in mind that clients can be very embarrassed about talking about their bowel habits. Very frequently they won't volunteer this information. We find out later that they've had issues for years with something that could have been addressed. And so we need to address it with a sense of maturity and, you know, allow people to feel comfortable discussing this aspect of their lives with us. So what we want to know is what's normal for them. Remember that there is a wide variation of what can be normal in clients, once a week to, you know, several times a day. So how often? We also want to know what's the consistency. Do they frequently have stools that are hard and dry and difficult to pass, or do they frequently have watery stools? Like those folks who have, say, celiac disease or Crohn's disease or ulcerative colitis, some kind of irritable bowel. Any change in bowel habits? Any risk factors we want to know? Are you eating fruits and vegetables and high fiber? Are you drinking fluids? Are you moving and being physically active? Do you ignore the urge to defecate on a regular basis? That can contribute to constipation. So we want to know, these are some questions that we need to ask. We might want to ask them about any changes in color or odor or consistency, any discomfort that they're having with defecation, any history of hemorrhoids. I'll just put discomfort or pain. And so those are the kinds of things that we want to know. We also want to know about any significant medical history. Did this person have maybe a diagnosis of irritable bowel syndrome? Or have they had foodborne illnesses? Have they had other issues? Any medications? And with this, yes, we're going to assess use of laxatives or stool softeners, suppositories, anything they're taking specifically for something for their bowels. But we also want to know any meds that have significant side effects for the GI system, and that's a lot of them, especially your oral meds. There are a lot of medications that are constipating and some that cause diarrhea, so we might want to know, okay, you say you've had a recent change in bowel habits. Are you taking any medications? Oh, your doctor prescribed an antidepressant, and one of the side effects of that antidepressant is dry mouth and constipation. Or maybe you decided to get healthy and take a multivitamin with a lot of iron in it. Those kind of things would have impact on the bowel habits. So if that's the person's complaint, we want to know anything that they're doing that's different and any current complaints. And next we have inspection. First we're going to inspect the abdomen, and then we're going to look mostly at the size, the shape, the contour. And when we're talking about alterations in bowel function, we're mostly going to be looking for abdominal distension. And distension is that sort of bloated swelling of the belly. We're also going to look to see if there are any visible masses, and sometimes it's more helpful to look at the patient both from the side of the bed and from the foot of the bed so that you can see different shadows and contours. So kind of looking from more than one angle can help you see if there's a visible mass. So that's mostly inspection of the abdomen. Now, when you get a stool specimen, or people, when you have a problem with bowels, you might want to inspect the product of bowel elimination. You might want to look at the stool. So there are different things that stool can appear. Normally we see it as a brown, soft but formed. We want it to have a shape, mass. Okay, so that's really what stool should look like. We all kind of know what poop is supposed to look like. I don't think that's really a shocker to you. But it can have different appearances. It can be dark and tarry. And sometimes that's an indicator that they've had a GI bleed. Sometimes it's just from iron supplements. So dark and tarry should raise your index of suspicion. If you see a dark tarry stool, you should really, unless it's a brand new baby, a newborn, less than 2 days old, But in an adult, if you see dark and tarry stool, you're going to ask them about iron supplements. You're going to ask them about questions that might pertain to GI bleeding. Bright red blood usually is superficial. It's usually coming from the rectum, and usually we're talking about hemorrhoids, fissures, something superficial in that region. You can have clay-colored stools, and they're kind of whitish. I'll get you some different pictures and put them up in a sec. And that's usually indicative of liver failure. And then you can have pencil-shaped stools. And these are very thin and narrow, and they usually tell you that the stool has to go around an obstacle. So either there's like a giant hemorrhoid in there, or maybe you have a mass of some sort, and that's sort of making your stools what they call pencil-shaped. They're very sort of thin and long. You might see mucus in the stools. These are all different things that you might see in the stool. And let's get some pictures. Okay, so I know this isn't the most pleasant part of your presentation, but this is the dark tarry stool, also known as melena, and I'll put that up here, or melena. Sorry, that comes up. Yeah, I hope nobody named their kid that. But melena is a sign that there is partly digested blood in the intestine. And so you have a GI bleed going on somewhere, and then the body sort of breaks it down, and you get this dark tarry stuff. Now, sometimes iron supplements can do that too. And they can also give you a false positive on a hemoccult test, which is the next part of our presentation. We'll talk about some diagnostics. But hold on, and I'll get you some clay color. So here's your clay-colored stool, and it can be whitish or gray. This is more like a pale flesh color. I apologize for all these pictures of excrement. It does make for a weird Google search, just so you know. But clay-colored stools mean that there aren't any bile pigments in the stool, and that's indicative of liver failure or cirrhosis. So suspect something when you see that. And there's a pencil-shaped stool. Again, you notice it's very long and very thin. And that means that the stool has had to go around an obstacle, and it can be indicative of an obstruction, like maybe a solid mass in the colon. So there you go. And everyone kind of knows constipation can look like hard, dry pebbles, whereas diarrhea looks like liquid stool. And you will start to, inspect stool probably your very first day in clinical. Fun as that sounds. And then we look at auscultation. Auscultation is listening, and we listen over the 4 quadrants of the abdomen. Sorry, let me get a picture of the 4 quadrants. And as I said, we listen first so that we're not hearing the clucks and gurgles that might be caused by the shifting of contents that we ourselves caused. And so usually when I listen to the bowel, I do a systematic pattern. You want to make sure you listen to all of it. So I start in the right lower quadrant, both because I am right-handed and usually standing at the right side of the bed, and because the ascending colon kind of starts here. And then we go up to the upper quadrants, and you listen to the transverse colon, and down into the lower quadrants where you're listening to the descending sigmoid colon in here. Okay, and so you would listen for quite a while to determine that there were no bowel sounds. You'd have to listen for at least 5 minutes. Normal is every 5 to 15 seconds, hearing high-pitched clucks, squeaks, gurgles. The best way to understand what normal bowel sounds are is to listen to your own and to listen to your friends, assuming you all have normal bowels. It's just like listening to breath sounds. If you want to know what abnormal is, start with normal and listen to it a lot. Listen to your cat, listen to your dog, listen to your friends, listen to your family, listen to yourself, and then you'll get used to what normal sounds like. Then when you get to the hospital and maybe you have a fresh post-op and you listen and you don't hear anything, or you only hear like one little cluck, and then 30 seconds or a minute later you hear another gurgle, that's going to sort of help you to understand what abnormal is. So that's auscultation. You want to have bowel sounds in all 4 quadrants. Especially important to listen in your post-op patients. You also have to ask your post-ops, by the way, and this kind of goes back to history, but when you're assessing your patients in a shift, if they've had abdominal surgery, you ask them if they're passing gas. And people giggle and they think it's weird that you ask them sometimes, but if everyone asks them, they don't. And that's because passing gas is the most reliable indicator of the return of peristalsis after surgery. And we can get into a situation called paralytic ileus after an abdominal surgery, where the bowel sort of gets stunned and then it's paralyzed. And it can be a very serious emergency. If that person ends up with paralytic ileus, they're going to vomit a lot. It's very uncomfortable, and of course, nothing can move past. So assessing the GI system is important. Palpation, mostly we're palpating to see if there's tenderness. A person who has bowel issues can have abdominal tenderness, and we're also palpating for any kind of solid masses. If you feel something like that, especially as a student, get somebody else to check with you. And then you would report that finding and document. Now, the last part of our physical assessment of this client is going to be percussion. And percussion is something that we will practice in 137 in the lab. You put one hand on the abdomen, the part where you want to percuss, and then you sort of tap on top of that hand. And what you're trying to listen for is a hollow sound called tympany. Tympany is normal over the intestines. It's most of the time your intestines are going to be mostly hollow. There will be little solid spots, but you don't want to percuss a dull thud over every surface of the intestine. That would be an abnormal finding. And that's your basic nursing assessment. Next, we'll talk about some diagnostic testing that we can do to assess the GI system. So it's important for the nurse to understand how to collect specimens and how to interpret results for our basic laboratory evaluations. And when we cover diagnostic testing, there are certain nursing implications: prepping your patient, educating your patient, and taking care of them following a procedure. And so the first thing that we're going to discuss is stool specimens, and you guys should be fairly familiar with this. The most likely thing that we're going to test for, there are basically two things: either infection or occult bleeding for GI bleed. So the infectious disease type tests that we can collect are our culture and sensitivity, or CNS, and our ova and parasites, or O and P. And you guys remember, we kind of talked about it. Remember that culture and sensitivity is going to tell you what organisms are growing or overgrowing, in the case of stool, which is loaded with bacteria, particularly things like C. diff. And we're going to know what agents can treat them. For ova and parasites, we're also going to look. When you collect that stool for the ova and parasites, remember to try and get anything that looks suspicious. If you see segments of a parasitic organism, or if you see anything that looks like eggs or ova, you're going to try and get that in the little collection tube that has that medium. Now, it's kind of a joke. They give you a little spoon or a scooper with some of these things. Generally speaking, if you're testing for O and P or for a culture, usually you're doing it because the patient has watery diarrhea. And so you're going to kind of get very good at learning to collect about 15 to 20 mLs of that liquid without getting it all over the place, because you don't want to spread any kind of infectious disease. And so, of course, this is a procedure you would be careful to always handle it with gloves. Anytime you handle it, label it within the room, and then kind of send it out. Usually takes about 3 days to result, so the patient might not know what they have right away. Occult blood, we do hemoccult testing or other guaiac testing in the stool. This can usually be done at the bedside, and that should be the familiar picture. Remember that there are some things that can cause false positive, particularly in the older hemoccult. I think there are some of the newer antibody-based stool testing that they're very specific to bleeding. They can't be really kind of faked, but still, if you're on medications that are like blood thinners like aspirin or heparin, where there might be some microscopic bleeding caused by the medication, you might get a false positive. So that's just something to be aware of. Vitamin C, iron supplements, and red meat can also cause false positive, and steroids too. Okay, so then we go on to the visualization studies, and we did not cover this in the lab, so I'm going to spend a little time talking about it. X-ray studies, we can do X-rays of the entire abdomen, or we can focus them. We can do CT scans with or without contrast. And there's a couple of different ways we can do this. Now, if we want to look at the entire GI system, we might give somebody a drink of that stuff so that those structures show up a little more. Sometimes they'll do an enema for the CT scan. To flush out that contrast medium, you're going to tell them to drink 8 to 10 glasses of water a day. Make sure they drink, and flush it out. With a colonoscopy, now for all of these tests, they're either going to be clear liquids or NPO. For colonoscopy, they're usually NPO after midnight. For the X-ray or CT scan, they might just be 3 or 4 hours of clears. But the colonoscopy, they're going to be NPO. They're going to do a really wicked prep. Most people will tell you this is the worst part of it. They drink something called either Go Lightly or magnesium citrate is another, like the generic name. And it's a very strong laxative that gets rid of all of the stool. And so their stool has to basically run like clear water by the time they're finished with the prep. So it's pretty unpleasant for that patient. The colonoscopy itself is performed under sedation, and so most people don't remember it. They just kind of go into a little sleepy phase, and then they wake up and it's done. With the colonoscopy can check for tumors, and it can look for polyps, and it can look for changes that are related to like ulcerative colitis and those kind of things. Similar to the colonoscopy is a barium enema. You see more colonoscopies now than you do barium enemas. Barium enemas involve instilling a special enema that has a medium that shows up on X-ray. Now, what's important to tell your patient, they're going to be on clear liquids for a while too. You want their stool to be clear, so they're going to do a colon prep as well. Again, until their colon is completely clear and the stool looks just like water. And then the enema is instilled. It's usually a little uncomfortable. They might have a sense of pressure or fullness. And then we use X-rays. We take X-rays. And sometimes you can see more with one or with the other. There can be different reasons for ordering either. Your education to this patient, number one, is to make sure that they're not pregnant, because that would be a contraindication. We don't want to expose them to radiation because it can harm the fetus. With the barium, their stools are going to be white for about 3 days. The more water they drink, the faster they'll flush it out. So that's going to be important education. And of course, you're going to let the patient know what the test is for and what they might experience with it. So those are some of the major lab tests and diagnostic tests associated with bowel elimination. So the next part of the nursing process is going to be nursing diagnosis, where we identify our problems. So we have all the diagnoses that relate to constipation. Let's kind of bring them up here, make them a little bit bigger. So we have constipation. Constipation can be acute or chronic, can be a transient thing that they're experiencing while they're in the hospital and on painkillers, or it can be something that they experience very frequently, and so we call it chronic. Perceived constipation is a diagnosis that applies to the person who could have normal, soft form brown stool, and yet, their need to have a bowel movement every day to feel normal leads them to use laxatives or suppositories or other aids. So we have that, sort of self-diagnosis, and they do this stuff to ensure more frequent bowel movements. And that can also be a health problem that we target with education. And we have risk for constipation. And that's an appropriate diagnosis for anybody who is at risk. And a lot of your hospitalized patients who are on painkillers, patients who have had surgery, patients whose diets are poor are at risk for constipation. So, that would be another nursing diagnosis that you could target, particularly if you knew that you had some good interventions for it. That would help that person. Diarrhea is the passage of loose watery stool, and so that is another nursing diagnosis. Okay, bowel incontinence is the involuntary passage of stool. We don't have as many, we don't have a whole list of different types of bowel incontinence, but bowel incontinence can be one of those problems that people have a very difficult time sort of talking to a healthcare provider about, and they may end up with some social isolation issues because of it. Dysfunctional gastrointestinal motility is one of those diagnoses. It doesn't mean a whole lot by itself. You have to specify decreased or increased. And this could be the person, when you listen to their bowel sounds, they're hypoactive, maybe they just had surgery, and you're not noticing any constipation. They're at risk for it, but they absolutely have decreased gastrointestinal motility. You could use that. as a diagnosis. And then toileting self-care deficit, this is going to impact a lot of your patients who are in the hospital and who might be on bed rest, or patients who can't ambulate to the toilet or can't toilet themselves because they have Alzheimer's, along with a lot of other self-care deficits where you might need to assist them to toilet. So those are your major nursing diagnoses that impact on bowel elimination. Now, some secondary nursing diagnoses that can be a result of problems with bowel elimination. Obviously, if you're having cramping and diarrhea, you have pain. Constipation can cause nausea, so you can have nausea related to constipation. And folks that have bowel incontinence issues, as we talked about, can have issues with social isolation. Now, one more thing I'm going to throw out there is body image disturbance. And that applies even though we're not really going to talk extensively about your folks with colostomy or other bowel diversions. But people who have colostomies often do have issues with body image disturbance. And so that is something that you should be aware of. Once you've assessed your patient and you've identified the key priority problems, it's time to, sort of make some goals and plan your interventions. So your general goal for most clients is that they have a soft formed bowel movement regularly, and it should be a pain-free process. They should not have, excessive pain with that. Of course, you're going to tailor your goals to your individual clients. Maybe your client was knowledge deficient or had deficient knowledge, and now the goal is to have the patient change their behavior or verbalize understanding. And so that might be a little bit different. But the general goal for most bowel elimination problems is that the person's going to have a somewhat normal bowel function. So for your patients who have constipation, we're going to look at things like promoting normal defecation. To the extent that we can in the hospital, it's not always 100% possible, but the first thing you're going to do is provide privacy as much as you can. I mean, some people are falls risks and you can't really leave them alone in the bathroom. You can't walk away and go do something else that might be time consuming, but you can close the door and be standing right there. Now, do not try to, every 2 minutes, are you okay? Are you all right in there? Do you need me? Because people will have issues when you do that. If you can provide privacy by, even closing the curtain and being on the other side of it, that's important. Now, while you're providing privacy, be careful that you don't put your patient on the bedpan, walk away, and 3 hours later go, oh no, what happened? My patient's been on the bedpan. People have gotten serious injury from that. They'll get pressure ulcers in the pattern of that bedpan. So do not leave your patient on the bedpan for more than, say 15, 20 minutes. You're definitely going to check on them every, say, 5 minutes or so. But providing privacy is an important intervention to promote normal bowel habits. The next thing that you're going to do is upright positioning. And you're going to, we'll go back. If the patient's on a bedpan, you're going to try and sit them up as much as possible because it's very hard to have a bowel movement when you're laying down in the bed. Some people have a really hard time with bedpans in general. So what we're going to do for that patient, very few people are on complete bed rest, some are, but we're going to promote the most normal means. And that means a toilet is better than a commode, which is, than a bedpan. Definitely. So the more normal you can make this experience for them, the more likely you are to have normal bowel function in that client. Okay. Obviously, you're going to provide hand hygiene. Also, control your facial expressions and just deal with the situation very matter-of-factly. People can be very, very embarrassed, and the more embarrassed they are, the less likely they are to have a bowel movement. And if they continue to ignore that urge to defecate, they will not only end up constipated, they may end up with an impaction, and believe me, that is not a situation you want to find yourself in. So those are some things that you can do to promote normal defecation. Now, your folks who have constipation, we talked about some factors that influence bowel function, so hydration, activity, nutrition. So we're going to promote normal food, fluid and fiber intake. Now, dietary fiber, normal amount for people is about 25 to 30 grams, but if they haven't had any, you want to increase gradually because it can promote a lot of gas when you kind of increase your fiber intake all of a sudden. You want to encourage activity. If you're in the hospital, get them up and walking down the hall. Walking. The more people walk, the healthier they are. I mean, some people can't. You will have people with mobility issues. But don't let your post-ops tell you, I can't walk, it hurts too much. Control their pain and get them up and walking. Okay? Now for collaborative interventions, we may have to administer some medications. So laxatives, stool softeners like your Colace, also known as docusate sodium, suppositories, and we'll talk about enemas in a minute. But those are some things that you can do. Now let's go ahead and start discussing enemas. You had a lab on enemas, and I know it was probably kind of icky for you. But we're going to talk about the different types of enemas and some nursing considerations with those. Okay, so in class, or in lab, you did a soap suds enema, also known as a cleansing enema. The only soap you can use with a cleansing enema, by the way, is cast-iron soap. Nothing else is okay. And these are large volumes. And the purpose of a large volume enema is to instill maybe 1,000 to 1,500 mLs of liquid. You're going to distend the bowel, which irritates it enough, and you're also going to soften that stool to an extent. You're going to add water to the colon, and the stool may absorb some of that water, which will soften it. And you're also going to distend the colon to the point where it's going to stimulate some peristalsis. Then you have hypertonic. Oh, by the way, let's back it up a little bit. When we're talking about these large volume enemas, your patient's ability to tolerate this is largely based on the flow. It's also based on the shape of their colon. But if your patient experiences cramping, and I'm sure we talked about this in the lab, lower the height of the container and just slow it down. It's also very important to make sure that the temperature of the solution is not too cold, which will cause cramping, and not too hot, which will cause burning. You really want like a warm solution. So make sure that when you're preparing your soap suds enema that you have taken that into consideration. Now we have other types of enemas. One of the types that you might be more familiar with are the hypertonic enemas, like your fleets, and that's something that you'll see on a lot of units, more than you'll see the soap suds enemas right now. And the way that a hypertonic enema works, it's very concentrated, it's smaller volume, so in itself it does not distend the colon, but what will happen is it draws fluid into the bowel. Remember, everything kind of wants to equalize those, if something has a lot of water and it's very diluted, it's going to be attracted to the solution that is more concentrated and less diluted. So we're drawing a lot of fluid into the bowel, and it's going to accomplish about the same thing. You're going to have a distended colon and rapid evacuation of the contents. Now you want to watch for patients who have issues with blood pressure. Anybody who has issues with sodium retention, you can absorb some sodium through the rectum and colon. So your patients with CHF, you're going to watch them. Any patients with like kidney problems. And the other thing you want to watch with anything that you're, any type of rectal stimulation you're giving, is that the vagal nerve is there. So people with cardiac problems, when you have to do a digital exam, when you have to do an enema, when you have to do any kind of disimpaction, be alert that that patient may have a cardiac dysrhythmia if you're not careful. They'll go Brady from the stimulation to the vagus nerve. And so you always want to have a doctor's order when you do anything like this that's invasive. And you want to make sure that you're really choosing their patients very carefully. If they've got cardiac issues, you want to be especially careful and look for signs and symptoms. If they start feeling dizzy, if they, if they feel palpitations or whatever, you're going to stop everything and assess that patient further and maybe intervene if you have to. So those are just some nursing considerations for those things. Then along the lines of other enemas that we have, there are oil retention enemas. These are also a small volume. You're looking at those little squeeze bottles. What we normally use them for is that problem that I've alluded to a few times, fecal impaction. This is constipation that's gone on for so long that the stool is like a little rock or big rock. It is impossible for the person to pass on their own, and we now need to disimpact them. This is a situation you want to avoid if you can. Keep track of when your patients have bowel movements. It sounds really simple and weird, but think about it. I worked in a long-term care facility for a little while, and we had a list of patients, and we knew when they had their last bowel movement. It was part of our jobs to keep track because they can get impacted, and that is a very seriously uncomfortable situation. And of course, if they can't pass stool, nothing that's above that impaction is going to get through either. They start to vomit. It's very uncomfortable, and it can cause a lot of serious problems for that individual. Then there are other sort of enemas. We have, the medicated enemas and the nutritive enemas, the return flow enemas. I don't want you to get too worried about those. A lot of times they can use enemas to relieve gas. What I mostly want you to remember are the large volume, the small volume hypertonic, and your oil retention enemas. Those are the things that you're going to see most frequently in the clinical area. So our next nursing diagnosis was diarrhea, and now just a word about preventing diarrheal illness. Most of it can be caused by bacterial contamination, and so hand hygiene. Remember your patients with C. diff. C. diff is the one illness where an alcohol-based hand rub is going to be ineffective, and you want to wash with soap and water. So we teach hand hygiene, and we monitor our own hand hygiene, disinfecting surfaces, particularly for people who work with young children, toys, changing tables, things like that. You want to disinfect with like a bleach solution or a specially prepared disinfectant solution, like we have our purple wipes or whatever. And then we're going to provide information in terms of prevention. Food intolerance and food allergies. If those are the, if that's the root cause. If we have diarrhea related to infectious disease or, some kind of infection, then we target that in one way. If we have diarrhea that's related to food intolerance, then we target with education there. Now, if we have diarrhea, there are a few things we can do. For independent nursing interventions, we have the brat diet. And brat is bananas, rice, cooked apples, or I like to say applesauce. Now, some sources say toast. I was taught tea. Weak tea has tannins that encourage more solid stool. But bananas, rice, applesauce, and toast are your basic brat diet. We need the person to stay hydrated, and particularly oral fluids as tolerated. Now, if you're also having vomiting and diarrhea, you might have to do IV fluid replacement. That's not an independent nursing intervention. That is a collaborative intervention, but just so you know that you keep the person hydrated. Other things that we can do are to give that person, particularly if our problem is related to antibiotics, encourage the use of probiotic foods such as yogurt. And that's going to prevent a lot of diarrheal illness that's caused by antibiotics. When you wipe out your good flora, the bad flora has a chance to grow, and that irritates the gut. If your patient's problem is exacerbated by stress, when they have irritable bowel syndrome or whatever, manage stress. And we're going to reduce the amount of fiber. So you follow what's called a low residue diet. And that's going to increase the amount of time that the food spends in the colon and keep that stool a little bit more solid. There we go. And I'll just give you a minute with that to kind of write it down. Those are the independent nursing interventions. Bananas, rice, applesauce, toast, and tea are the brat diet. And then, of course, you need to make sure if that person's losing fluids for the stool that they're replacing it either through oral means or IV means. Encourage that probiotic to replace the good bacteria. Manage stress and reduce fiber. So. Now, most diarrheal illness, most of your stomach bugs run their course and then they're done. And we don't try to stop diarrhea with medication because we want those organisms to be flushed out of their body. However, with chronic diarrhea, people who sort of have this loose watery stool all the time, who are always at risk of losing fluids, people who have various, ulcerative colitis and Crohn's disease, we might give them some opiate derivatives like loperamide. Or it's called Lomodal. And remember that the narcotic opioids cause constipation. Well, these also decrease the motility of the GI tract. And so we would administer these under the supervision of a provider. Bismuth subsalicylate is also known as Pepto-Bismol, and it's great for traveler's diarrhea. It's kind of a mild over-the-counter. You can use kaopectate's, another one is pectin, that'll bind the stools, make them a little bit more solid. But again, this is for the person who has like a chronic, non-infectious diarrhea. And so those would be some interventions for that. So the next problem we're going to look at that's related to bowel elimination is bowel incontinence, which is the involuntary passage of stool. And our goal for this person is going to be a little bit different. Or if it's realistic, we'll help that person achieve voluntary control of defecation. If it's a functional limitation, or if it's caused by something we can fix. Or if we can't help that person achieve that goal, we're going to help them minimize complications of bowel incontinence, such as impaired skin integrity. And so there are different causes of bowel incontinence. So when we're writing our nursing diagnosis and we have a related to statement, it could be related to impaired nervous functioning. So maybe you have a problem with nerves that supply the rectum and the anus, and that person no longer senses the urge to go. Or maybe we have pelvic floor weakness or injury. Maybe the anal sphincter is weak, so we don't have that kind of control. Uncontrolled diarrhea. And in that case, we would target the diarrhea, as the related to factor. If we can control the diarrhea with things like the brat diet or medications, then we will. And also we have fecal impaction as a related to factor. And the reason that can occur, we know that a person can't pass the impacted stool, so liquid stool can sometimes leak around it. And that can be one of the signs of a fecal impaction. So we would resolve the impaction and hopefully restore voluntary control. We can have cognitive changes or developmental disabilities. People who have profound cognitive changes will not recognize or respond to the cues to defecate. In a toilet, they'll kind of just go. And so those people, usually we're minimizing complications. It's our second goal. And then we can have functional limitations. Similar to functional urinary incontinence, we can have people who really have to get to the bathroom and they can't get to a toilet in time. So those are some of the things that can cause our bowel incontinence, and so we target those causes and we plan our care accordingly. If we have something that we can't fix, we try to minimize complications of the incontinence. So what are some things that we might do? Now, if we think that we can achieve continence, and we're using that as our goal to have that voluntary control, we have the following interventions. Really, it's like a bowel training program. We're going to give that person frequent reminders and assistance, hourly rounding. So that person with cognitive changes, person with Alzheimer's who forgets to use the toilet, We might have to go in hourly and find out if they need help with the toilet. We might have to, at regular intervals, say after meals or after snacks, sit them on the toilet and wait if we know what their pattern is. We're going to review their diet, their fluid intake, their activity and medicines. If they have certain foods that are triggers, if they have, say, a Crohn's disease where certain foods, raw fruits and vegetables, aggravate their diarrhea, we're going to remove those triggers, okay? If they're impacted frequently and that's what's causing the incontinence, we're going to increase the fiber in the fluid. Hopefully we can get some activity. Even range of motion, passive range of motion in the bed will stimulate some peristalsis. And we're going to look at any medicines that create that uncontrollable diarrhea. So we're going to educate the patient to look, if they're in a position where we can educate them, to look at those risk factors and sort of eliminate the triggers. If, say, they're very sensitive to gluten or to caffeine or to, anything, we're going to remove the things that cause that problem for them. We can collaborate with the provider. If we know that maybe the patient has an issue with a certain medication, say it's metformin, the patient has diabetes and the doctor puts them on metformin and the metformin creates a sense of urgency that they have to defecate immediately and they can't get to a toilet, and that's caused an incidence of bowel incontinence. We might have to talk to the provider about getting a different form of the medication or a lower dose until the patient becomes tolerant to it. So those are some things that we can do. And then, of course, always addressing the underlying cause. If it's a functional issue, if they can't get to the bathroom in time, maybe you want to get a bedside commode that's close to the bed. Maybe you want to remove obstacles that are on the way to the bathroom. Maybe you want to move them if they're in their home and their bedroom is down the hall, move them to a closer room. Or again, if they're in the hospital, maybe we want to offer that bedpan a little bit more frequently. If it's a diarrhea issue where they just have uncontrollable diarrhea, we're going to treat that. If they're impacted, we're going to prevent impaction and disimpact as needed. So those are some things we can do for the person who we're trying to get them to have voluntary control. Now, if the issue is preventing complications, we're going to monitor that patient. And if we find that they have been incontinent, we're going to want to change the linens, the clothing, and any kind of incontinence product they're wearing, like briefs or underbed, underpads. We're going to change all that, right away, because stool is very caustic to the skin, can be a major contributor to skin breakdown. Now, speaking of the use of incontinence products,
get out of the park on the road. Roll on the road.
Don't call them diapers. Definitely call them briefs, or you can, refer to the pads, but don't call them diapers. It's demeaning to the person, so you really don't want to do that. Other things you want to do, or you want to maintain skin integrity with meticulous hygiene. You guys are going to go to clinical, and you are going to see a lot of people who are maybe a little bit debilitated, and they're going to have one of the biggest spots for pressure ulcers is going to be the sacrum, and one of the biggest causes of that is fecal incontinence. And even urinary incontinence, because you have that sort of wetness always in contact with the skin, and then if you don't turn them often enough, you're going to have the pressure on the sacrum. It's a bony prominence. You can apply barrier creams and use like special perineal cleansers. And they usually leave sort of a protective film, plus they don't force you to scrub the skin too hard, and there's a lot of no rinse formulas. And then pat the skin dry after cleansing before applying that cream. Okay, and there's some really good products on the market. Now, another thing that you might want to do, again, we're looking at that sacral area. There's something called a Mepilex dressing, and you will see these on the floor a lot. A lot of your patients have them. It can be a nursing measure. They don't have to wait until they get skin breakdown. If they're at risk for it because they're incontinent And because they have thin skin and they're elderly and they're laying in bed for long periods of time and not getting out of bed, we can apply it. It's like a big Band-Aid. It's called a Mepilex dressing. Okay, so I'm just going to call your attention to some of these external fecal collection devices, and they're similar in concept to either an ostomy appliance that you would put on a stoma. I did say that I was going to kind of leave out our discussion of colostomy for now because we get back to it later, but I will show you a picture in a minute. But also is similar to like the idea of a condom catheter where you put something on a patient to collect the products of the incontinence. So this is one that you would take off the adhesive barrier and then kind of press around the skin of the anus, and it would collect liquid stool, hopefully. The problem with it is, should be kind of obvious, they don't always stick where you want them to. They end up in the bed with all the stool that it didn't collect. If you can really get it to stick on there, you might have to even, remove, if the patient's very hairy, remove some hair and get it to stick. But they're not real popular. I haven't seen many people use them. Most people just kind of use the absorbent products. This is another type of external fecal collection device, and again, when you have like a person who, say, has a lot of liquid stool, somebody with C. diff, somebody who's on tube feeds, whose output is very liquid, you can put this device in, and I want to take a pointer and kind of show you. This part has a little balloon, very similar to a Foley catheter balloon. And here is where you blow it up, so you'd sort of lube this up and insert it past the internal sphincter and blow up this balloon, and it would collect the fecal material down into this tubing and into this bag, and you could empty the bag in theory. And sometimes that works really well, to have that sort of rectal tube with a collection device. People can use rectal tubes also to remove flatus, which is intestinal gas. So those are some interventions that you might see for bowel incontinence. And the big thing with bowel incontinence is to keep the skin clean and dry. If you can't resolve it, and then to control odor, and the person who's living with issues that have social isolation, you're going to have to find a way to sort of manage the incontinence so that they can have some sort of life. Otherwise they can get very depressed. And so that is our interventions. And I'm just going to kind of roll into evaluation of goals. Because that's like a 2-minute discussion, and rather than make this video a whole lot longer by creating a new slide, we're just going to talk about when you evaluate, you go back to your original goal. Is the person having a soft form bowel movement on a regular basis? If not, reassess and see where the problems are. Is it an issue of noncompliance with the bowel program? Is it an issue of deficient knowledge? Are we still not getting the fiber and the fluid in the diet? Has the person got some kind of disorder that hasn't been diagnosed? Maybe they thought it was irritable bowel, but it's really ulcerative colitis or Crohn's disease. So those are some things that we can look for to evaluate whether our intervention was successful. Incontinence, we're really going to look at what our end goal was. Risk for impaired skin integrity might be our goal. And so if the person maintains intact skin, we've met our goal. If not, now we have impaired skin integrity, an actual problem. We have to make a new care plan to address that. So that is how you would evaluate your goals, and that is it for elimination.